Okay, finally got set up. Okay, so review will be tomorrow. We'll do the review tomorrow, the Kahoot tomorrow. A little bit closer to your exam on Friday. I put this question up just as a thinking question. We're going to actually get to learn how this works by the end of the lecture today. So patient comes in, they're volume overloaded due to congestive heart failure, so the heart is not pumping anymore, so we have a backup of blood in the system. They swell up with fluid, the legs get very big. Normally we give them a diuretic called Lasix. There's a bunch of them, but we're going to talk about diuretics today. At the end of the lecture, this will be an answer you can figure out, so we'll figure that out towards the end. When you guys are studying the cardiovascular system for your review for Friday, when you're studying, make sure you understand the cardiac function word and what are the vascular functions. Cardiac functions, preload, afterload, cardiac, contractility, and compliance. Those are cardiac function things. The vasculature has an effect on the heart. So that's how we know what's going on. But when you're studying like systolic blood pressure, diastolic blood pressure, MAP, all that regulation of blood flow, those are vascular terms, all doing with the vascular system. If we talk about vasculature and our systolic blood pressure goes up because of arteriosclerosis, then you know that if we increase systemic vascular resistance, because our blood pressure is going up, that's going to have an effect on the heart through what term? Afterload. So afterload senses what's going on in the periphery because we have to overcome that systolic pressure to get out the heart. It's a vascular thing that's affecting the heart. Remember, the heart is just a pump. That's all it's doing. It's generating enough pressure and relaxing. That's all it does. Preload, what affects preload with regards to the vasculature? Venous return. So we talked about ways we alter venous return, and that's why I said also, make sure you understand venoconstriction. Because venoconstriction is talking about the veins. If I squeeze the veins, what happens to your venous return? Increases. If I increase my venous return, what happens to my end diastolic volume? Goes up. My EDV goes up. What happens to my stroke volume? Increases. But also mixed in the middle of there, what cardiac function word also goes up? Preload. Preload goes up. Contractility also goes up. Why does contractility go up? Yes, but before we even get, why does the cells become more sensitive to calcium? What's going on? Stretch. The heart's going to stretch to accommodate more volume of blood coming in. So the heart's going to get stretched. When the heart stretches, it becomes very sensitive to calcium to allow for a stronger contraction, getting all that blood out. Therefore, stroke volume goes up, cardiac output goes up. So when you're studying, the first block that we did the majority of was just cardiac function. Everything else was talking about the vascular system, the capillaries, lymphedema, the lymph system, oncotic, hydrostatic pressures. Those are all vascular things. The heart just pumps in and out, whatever it's going to do, depending on the pressure in the system. So let's get started with renal. Okay. So today, lecture one, we're going to talk about the renal system, glomerular filtration and clearance, renal sodium handling, and diuretics. Tomorrow, we'll do a little bit of electrolyte balance, ECF, so our water control. That has to do with a lot with antidiuretic hormone or vasopressin, that posterior pituitary gland, how we form urine and concentrate it. And the last one, more acid-base and micturition. What's that? Peeing, urinating. That's the medical term. It's called micturition. Okay. Here's a little meme for you guys. I haven't had it in a while, so that cheer you guys up. Okay, you can read that. Okay, so the renal system itself, the main hydrostatic variable that we are worried about in the system is ECF. That's the main homeostatic variable for the renal system, extracellular fluid volume. It's going to sense the volume of blood. It's going to act on it through renin. It's going to control with urine how much sodium, potassium, calcium, magnesium stays in the blood versus what we pee out. All through the renal system, again, we are looking at extracellular fluid volume as the main variable there. Here's our anatomy of the kidney. Obviously, all the urine forms, goes into the calyxes and eventually into the ureter, which gets stored in the bladder. So obviously, when someone comes in with volume overload, there's two things that can potentially be for the most part, either a kidney issue or a heart issue. And then your job is to figure out, is it a heart or a kidney issue? If they already know they have heart attacks and all these other issues, it's probably going to be a cardiac cause. But if they have long-standing blood pressure issues, long-standing diabetes that's uncontrolled, they decide to go crazy on a weekend and do a bender of cocaine, they can blow up their kidneys real fast, then you have a kidney problem. So the kidneys are obviously very sensitive to a lot of things. The cortex is the outer region, the dark region, and the medulla is the inner portion of the kidneys. The functional unit of the kidney is the nephron. Each kidney has between 500 to 800,000 nephrons. So whenever you're talking about kidney failure, they're losing nephrons. And it's a gradual start. They'll lose some. Over time, they'll lose some more nephrons. They lose more nephrons. They have to lose a good portion of their nephrons before you start seeing some changes in their kidney function. So there's plenty of nephrons there. We have two kidneys, so double them up. And then we actually have different segments within the nephron. So here is our normal structure of the nephron. We have the glomerulus, and that is the main site where these afferent and efferent arterioles happen right there, that little collection of all these vessels, and that Bowman's capsule is right there. This is where the filtrate is first dumped in. So we dump in the filtrate. Remember, the hydrostatic pressure at this point is strongest. Sorry, I keep kicking your backpack. So that's, what is the hydrostatic pressure? Is that the push or the suck? Push. So the push is going to win for the most part. So we're going to push fluid into the Bowman's capsule. Once we're in there, it'll be called tubular fluid, aka urine, but we just call it tubular fluid at first. It really becomes urine more when it's done through the whole kidneys and it's in the bladder. So that's the glomerulus, is the Bowman's capsule, the very, very first part that we get into the kidney. Then we have the proximal tubules. Again, we're just following along the line. It travels along. At the loop of Henle, it's a U-shaped curve. We have different parts of it. We have the thin descending limb, thin ascending, and a thick ascending limb. Why am I pointing it out? Because different diuretics and different things have different effects at different parts of the nephron. Distal tubule is the very, very end part. And basically at this part, we have 6 different distal tubules that converge with a single collecting duct right there. And then finally, this goes into your major and minor calyxes, ureter, bladder, urethra, and then out. Okay, so that's where your anatomy comes into play. So these are the different parts of the nephron. Within nephrons, we have different sizes of the nephrons depending on how deep that loop of Henle goes. The majority of them, 85%, are going to be these cortical nephrons. They just hang out in the outer cortex, very short loop of Henle. Here is the line that separates the cortex from the medulla. And you can see in a cortical nephron, short loop of Henle, a little bit goes into the medulla, but not much. Then we have a smaller amount of these juxtamedullary nephrons. They're juxtamedullary, medulla's in the word, so we know these nephrons go into the medulla, or medulla, what do you want to call it? Okay, why is this important? For this reason alone. When your effective circulating volume is low, so like low blood volume, not much blood is going to get to the kidneys anymore. So when that happens during periods of hypovolemia, we'll store blood in the vasa recta of these juxtamedullary nephrons to help conserve your extracellular fluid. Remember, that is the main goal of the renal system. What's the main homeostatic variable for cardiovascular system? Cardiac output. What is it for the pulmonary system? PO2, oxygen levels of the blood. That's the main thing with the lungs. With the kidneys, nephrology, it's ECF. So juxtamedullary nephrons are helpful when you have hypovolemia. You need to preserve that extracellular fluid volume. We can hold blood in there through the vasa recta. Also, notice there are lots of blood supplies going all over the entire nephron. This is important when we talk about filtration, secretion, reabsorption, and where they occur. We dump everything into the Bowman's capsule, but then we pull stuff out that we need in our body still. And when we get through all those different parts, you'll see what we pull out and where. So let's talk about glomerular filtration, so urine formation. We will filter 150 to 200 liters of fluid daily by our kidneys. Obviously, we are not peeing 100 liters a day. So we have to reabsorb about 98% of that we get back into our system. Glomerular filtration rate is a controlled variable and constant. We want a constant glomerular filtration rate, GFR. That means that the kidneys are constantly being perfused and filtration can occur. When GFR starts dropping, you get renal insufficiency. So a GFR, it's calculated in your labs. The magic number to remember for GFR is 60. If they're below 60 in a GFR, they have kidney problems. Be careful with what you give them, because if it's excreted or metabolized by the kidneys, will that drug get metabolized if the kidneys aren't working? What's going to happen to that drug concentration in the blood? It's going to start going up. So some of the things you need to think about. If they have kidney failure or liver failure, how is the medicine you're giving them, how is it metabolized? Because if it's gone through the kidneys and they have kidney failure, don't give them that medicine. Tylenol. Okay, Tylenol goes through the liver, but the other NSAIDs go through the kidneys. So if they have liver failure, don't give them Tylenol. If they have kidney failure, you can give them Tylenol. Don't give them like ibuprofen or Motrin or those things. So 60 is the magic number for GFR. So like I said, 98, 99% of that filtrate is reabsorbed back into the blood. So obviously you know you're not peeing that much a day. The reabsorption for most substances is in the proximal tubule. As we go through the nephron, you'll see for all these different electrolytes that we go through, potassium, sodium, magnesium, calcium, whatever, the bulk of the reabsorption happens in the proximal tubules. When you get to the distal part, that's that fine control. So think about it. If you are filling up a cup of water, do you turn the faucet on if I told you I want to fill up your cup to the very top, and you have a big Stanley, would you let it go very small drips into the cup first? You put it on full blast, and as you get closer to the top, you slowly turn down the faucet so it gets slower and slower and slower. Same thing with the kidneys. In the first area, proximal tubule, we get a lot of reabsorption back. As you get to the later parts, smaller and smaller it gets reabsorbed. So the fine control of excretion is in the distal parts of the tubule. And the reason for that, it's under hormonal control. The hormones, aldosterone is the big one, has an effect at the distal convoluted tubule and the common collecting duct right at the end there. And you'll see where aldosterone has a role later on. So these words you got to know, these are some definitions. Filtration only, whenever you see the word filtration, that means that the blood is, the filtrate all happens at the Bowman's capsule. That is filtration. It only happens at the Bowman's capsule. In B, we have filtration and we have partial reabsorption. This is the reabsorption right there. You see that black line is leaving the tubular fluid and going back into the blood. We are reabsorbing whatever that substance is. It happens after the Bowman's capsule. That's reabsorption. You also can have filtration with complete reabsorption. So we filter, substance comes into the filtrate, but because we have complete reabsorption, everything gets reabsorbed, nothing comes out in the urine. That's complete reabsorption. When you use the word reabsorption, does that mean it's the first time we're getting this in or the second time? Second time, we're reabsorbing it. Where does the first site of absorption occur? In the intestines. We haven't gotten there yet. We'll get there next week. The intestines is the site of absorption. Everything from the outside getting in, we absorb it through the food. When it's in the kidneys or in the other parts of the intestine, we're going to reabsorb certain things to bring it back in. So this is complete reabsorption. The last one is filtration with secretion. Secretion, we're putting it back into the filtrate, but it occurs after the Bowman's capsule. So filtration, in the Bowman's capsule, everything gets dumped in. Reabsorption, we're going to pull some of it back out into the blood. That's partial, or a complete reabsorption, we get all of it out of the urine back into the blood. Secretion is putting a chemical back into the tubular fluid after the Bowman's capsule. So as we start worrying about other things, these words will start popping up again. Filtration, secretion, reabsorption. Make sure you know where they occur and what's going on with those things. So here is our nephron, and let's start talking about different segments and what their purpose is and what they do. Okay. The first area, we'll do it in black. This is called the Bowman's capsule, also known as the renal corpuscle. This is just the first site of filtration. Bowman's capsule, all the filtrate gets dumped in here. The next one, this is the proximal tubule. And this is the first site of reabsorption and the first site for secretion. This happens in the proximal tubule. Below, we'll talk about what ions and what are transferred in and out. Second part, or the third part, this is your nephron loop, also known as the loop of Henle. And in this area, we dilute or we concentrate. Dilute or concentrate the urine. That's the job of the loop of Henle. So obviously, we're talking about dilution or concentration. What substance is going to be highly movable in this area? Not so much sodium. Well, sodium, and also what else? What goes with sodium? When every time you water. Always remember, if you increase sodium, wherever it goes, water is going to go with it. That's why at bars they serve pretzels and chips for free. And they're salty. So you get thirsty, so you want to drink more. That's why they do it. So that's the nephron loop. Then we have, there's the distal tubule. And this area and the last one is the collecting duct, or a common collecting duct, common cortical collecting duct, CCD, however you want to call it. It's just where everything gets brought back into one big tube. At this point, we're pretty much fully formed and ready to go. But this area, hormonal control. So that distal tubule common collecting duct is under hormonal control. And mainly aldosterone is here and a little bit of ADH. So that's the structural parts of the nephron itself. Now let's talk about what actually is being moved in this area. So right in the beginning, remember this is the initial dump of all of the solutes. So in this area we have ions, water, and other nutrients. So now we're at what's the next structural area of the nephron outside the Bowman's capsule? What's it called? Proximal tubule. Proximal collecting tubule. At this point, we're going to reabsorb sodium, potassium, water, and other nutrients are going to be reabsorbed. It's purple, it's pulling out of the tubule. So sodium, potassium, water, and nutrients. We're going to add in, or this is where it could potentially be added in, hydrogen. What is that term called when we add in hydrogen outside the Bowman's capsule? Secretion. So we're secreting hydrogen into the proximal tubule in this area. Now, as we go to the loop, either we can reabsorb water in the descending limb. On the ascending side, sodium and chloride, your salt. So if we're pulling out salt, water is going to go with it, and you'll see wherever the water goes from there. As we start getting to the distal tubule, we're going to reabsorb sodium and water again. Also, towards the later parts, hydrogen and potassium. Potassium is very weird. We'll get to potassium probably tomorrow or on Thursday. Potassium acts very weird when it comes to the end part, but we'll deal with potassium all by itself in its own section. In the cortical collecting duct, common collecting duct, we have that final little bit where we can pull out sodium and water, and we can have this dual system here where we can either filter or secrete hydrogen and your potassium again. That's where each part gets either reabsorbed, secreted, filtered, and so forth. So this is like a general view of what we're going to be doing for the next little bit as far as different sections. We're going to take sodium by itself, see how sodium works. We'll take water by itself. Tomorrow we talk about concentrating or diluting our urine. Keep this in mind when you're studying this section for renal. The body doesn't care about the urine. The urine is waste. It's the makeup of our urine. We compare it to our blood just for comparisons. But the body doesn't care how the urine, what the concentration of the urine is. It cares about the ECF. And that's all it is. So if we need to add things or take things away from our ECF, we dump it in the urine and we get rid of it. Excess fluid, the same thing. We get it in the urine and we get rid of it. Again, when you're thinking about studying this thing, it doesn't matter what the urine is. It only matters what the ECF is. Okay. So let's talk about renal blood flow. Normally, kidneys get about a quarter of our cardiac output. We need a high renal blood flow. It's not RBF, resting, whatever, you want to know the rest. Now that's in your mind. Every time you see it, that's all you're going to think of. Okay, we need a high amount of renal blood flow perfused in the kidneys to get enough plasma for filtration. And that's why we talked about MAP, mean arterial pressure. This is just a number that we calculate based off of their blood pressures. And remember, what other system is also auto-regulated across MAPS? The brain. Brain and the kidneys are the only two ones that have this auto-regulation. And the purpose of that auto-regulation, constant flow of blood across a wide range of pressures. We need constant blood flow through the kidneys so we have time for filtration and so forth. We can alter renal blood flow through sympathetic vasoconstriction if ECF must be conserved. If we're having hypovolemia, we're in shock, we're losing blood somewhere, we have to conserve our extracellular fluid. So by shutting off blood flow to the kidneys, we can keep that blood going through the body, and that's why the kidneys are so susceptible to injury, because they can get cut off from blood supply very quickly. Okay? All blood goes through the kidneys, passes through larger branches of renal arteries to reach those glomerular capillaries. So the glomerular capillary bed, this is still capillaries within that Bowman's capsule, has an afferent arteriole and drained via efferent arterioles instead of venules. This is different compared to capillaries in the system. In the renal system, it goes from an afferent arteriole to an efferent arteriole. That efferent arteriole will then become an afferent to another nephron, so further filtration can happen and so forth. So resistance, remember these are arterioles. What's special about arterioles? We can squeeze them. We can control their radius. That's the site of the greatest vascular resistance are these arterioles because they have a good, strong muscle layer. And we can control that. We're going to talk about how we change resistance with the afferent side and the efferent side. What happens to your renal blood flow, your GFR, when you start altering the afferent and the efferent arterioles. We have a peritubular capillary bed. Peritubular, these are the ones that are, remember I told you in the beginning slide, the picture, that the vasa recta, the blood supply that surrounds the entire nephron, these are these peritubular capillaries. That's where reabsorbed solutes and waters go. Has efferent arterioles there. Filtration of protein-free fluid. Again, we don't want proteins in the kidneys. Keep the protein in the blood. And it helps with water reabsorption because we still have that oncotic pressure in the capillaries. It doesn't change. Oncotic pressure, remember, is the suck. If we're sucking water back in, it's a reabsorption of water. And here's that vasa recta that surrounds the loop of Henle's. Urine concentration, again, that's where a lot of that stuff happens. And again, here are looking at the different structures. There's more. Largest vascular resistance, afferent, efferent. The drops are the greatest in those arterioles. Again, site of greatest vascular resistance. And we can alter these if we need to change up your perfusion, the glomerular filtration rate. And that's why we always target the afferent and the efferents. And they have different triggers as well, and we'll go through those as well. So, again, high rates of renal perfusion gives large excess of O2 for tissue metabolism. However, in states of shock, kidneys are easily injured. And why do they get injured? Low blood flow to the kidneys. And that results in acute renal failure. So when it comes to acute versus chronic, it's all about time. How long are you in this renal failure? If it's over 3 months, it's chronic. Anything in acute stage, obviously, is going to be acute, hours to days. When it comes to acute renal failure, there's 3 different types of acute renal failure. It all depends on location. Pre-renal, anything happens before the kidneys. Hypovolemia. If you have low blood because you got cut and you're bleeding out everywhere, that problem is before the kidneys. That's pre-renal. If it's renal, acute renal, that means it's within the renal parenchyma, the renal tissue itself. This is just damage to the tissue itself. Okay, nephritis of the glomerulus. Post-renal, acute renal failure, anything after the kidneys. So benign prostatic hyperplasia, BPH, kidney stones, or an obstruction after the kidney. So that's considered post-renal. So those are different things about as far as renal failure is concerned. Other functions of the kidneys, endocrine functions with regards to renin. Okay, renin starts the cascade that goes from renin to angiotensin 1, angiotensin 2, aldosterone. We'll deal with that a lot more when it comes to endo. We'll touch on it a little bit right now. The reason the kidneys have a function when it comes to volume is when the blood comes in through the afferent arteriole, we have this macula densa. And this macula densa is right here. It's these cells right here. And because they are so close to the afferent and efferent arterioles, it could sense blood volume or effective circulating blood volume. If the kidneys sense that they're not getting enough blood flow, it gives out renin, and the whole cascade ends with aldosterone to increase your blood volume. Raise it back up again. One of the problems you see with people who have high blood pressure, is one of the underlying causes is what's called renal artery stenosis. So the artery that feeds the entire kidney, you have a left renal artery and a right renal artery. If that artery undergoes atherosclerosis, just like any other artery in the body can, let's say your right kidney in that artery has some stenosis going on. What's going to happen to the blood flow going to that kidney? It's going to be reduced, right? Because you have obstruction of flow. You have a blockage there. That kidney is going to sense low blood volume. So it's going to start this whole renin cascade to raise your blood pressure. But you don't have high blood pressure. You just have a blocked renal artery. So when you are looking at high blood pressure, really look at underlying causes. What could be else going on with that patient, not just normal idiopathic hypertension? So that's one function, endocrine function of the kidneys, is with renin secretion. The other one is EPO, which we've already gone over with regards to blood. Again, low O2 tension coming into the kidneys will release erythropoietin to get those stem cells to start making more red blood cells to increase the O2 carrying capacity of the blood to bring our O2 back up. So that is, we've already gone through that with EPO. The last one is vitamin D. Okay, vitamin D, mainly from the sun. Okay, so that's why you see vitamin D3, deficiencies causing problems. We're not out in the sun anymore as much as we should be. Normally, we were out in the sun like 80% of the time. Well, I know you guys are in school all day, but study outside, I guess. I don't know. But anyway, we get it from the sun, or we can take it exogenously via tablets and caplets. But when we get this D3 coming in, it's synthesized in the liver to make the inactive form of vitamin D3. This has to be activated by the kidneys. The kidneys turns vitamin D into the active form. So if you don't have a functioning kidney, are you going to activate vitamin D? No. Vitamin D is required for calcium. That's why if anyone like your parents are taking calcium supplements, they have to take it with vitamin D. Because if you take calcium without vitamin D, you can't absorb it. That's why vitamin D is important, because the effect is bone mineralization, increased calcium absorption by the intestines. It's under the influence of vitamin D. So you take them both together. Okay? And also parathyroid secretion, which we'll get to in endocrine regarding PTH and calcium secretion. But that's why vitamin D is important. Any questions about other endocrine functions of the kidneys or the functional units and whatnot. Okay, so let's talk about glomerular filtration. We don't want blood or plasma proteins to get into the urine. We don't need them in there. Okay, we're not spilling them. We just need the waste products to get out. Protein is not a waste product. Your red blood cells are not a waste product. You don't want them going into the kidneys. We have Starling's forces here again. We learned those a little bit with the capillary stuff, with the vascular function. Same rules apply here. Okay, and GFR is generally stable because of this autoregulation, but we can alter it based off of those afferent and the efferent arterioles. So when it comes to glomerular injury, we call it glomerulonephritis. And in all cases, you're going to see either protein or blood in the urine. And we classify them depending on what do you see. If it's nephrotic syndrome with an O, that means it's protein. So think of O, nephrotic O protein with the PRO, O. Protein in nephrotic syndromes. With nephritic, with an I, that you have hematuria. Now you have blood in the urine with nephritic syndromes. And also, they also increase your BUN and creatinine concentrations with nephritic syndromes. So whenever you see nephrotic, it's a protein issue. Nephritic are blood. There are some in the middle that kind of have a mixture of both, but don't worry about them for now. Now, our barrier for filtration, two things: size of the molecule and the charge of the molecule. Those two things are a barrier to keep chemicals or structures or solutes, out of the tubular fluid into the urine. So substances less than 10 kilodaltons are freely filtered. From 10 to 70, there's a decline. Albumin, what's albumin? Protein made by what? The liver, okay? Albumin is right at about 70 in its size. So it's almost small enough that it can get filtered. But we don't want proteins in there. So there's a second way to get proteins out. And that's due to electrical charge. At a normal pH, proteins carry a negative charge. Normally, we're negative in the space, in that Bowman's capsule is a negatively charged area. Because proteins are negative, will a negative substance go into a negative area? No, so you're repelling that protein. So it doesn't get into the urine. So molecular size, proteins are just barely big enough to fit through, but they don't get in because inside that diffusion area is a negatively charged space. At a normal pH, proteins are also negative, so that repels it as well. So there's two ways for barriers for glomerular filtration: size of the particle and the charge. What's the charge of the particle? So there are three layers that a solute has to go through. Just like the layers of diffusion in the lungs, there's layers of diffusion in the kidneys as well. We have the glomerular capillary endothelial cell layer. This is on the capillary end. Has large fenestrations, and it only excludes blood cells. Then we have the glomerular basement membrane. There's a fiber meshwork, acts like a sieve for macromolecules. So if you ever have like a strainer, only certain sizes can get through it. That's what this basement membrane's like. It's just a sieve, it's a wire mesh, not wire obviously, but it's a mesh and only certain size particles can get through. We also have podocytes here as well, and they're by a protein called nephrin, and they are this little slits. So again, just like in the blood-brain barrier, they have podocytes there to allow certain size molecules to get through. And again, fluid negative charges are present in the basement membrane and in the slits. So any negatively charged molecule will not get through. Okay, so let's take this out in little areas. So this is just this part of the membrane blown up as we look at what can get through and what can't. So let's set this up. We have our here's our glomerular capillary. In the middle is our basement membrane, and on the right is the Bowman's capsule. Okay. Everyone good on the bottom part? Glomerular capillary, obviously it's red for the blood. We have the space in between and our Bowman's capsule. The space in between the basement membrane, what charge is that? Negative. So we have negative charges here. Negative. Okay. These holes in the middle, these are the fenestrations. And we have on the opposite side, these are the podocytes. Let me change that color. Okay, so we have these little podocytes on the glomerular capillary end. Okay, the top one, the big red one up top, this is a blood cell, red blood cell. And red blood cells can't get through because the fenestration's not big enough on the capillary side, so red blood cells don't get through. They can't. Next up, this is a negatively charged chemical, whatever it is. Can a negatively charged one get through? Nope. It gets blocked off because the middle part, the basement membrane, is negatively charged, so anything negative can't get through. The little blue one is a mid-sized protein. So these mid-sized proteins can get through the fenestrations, but it can't get through the rest of it for two reasons. What are the two reasons it doesn't get all the way through? Charge. Yep. And the other one are these podocytes on the Bowman's capsule side. Those two things keep proteins out. So the mid-sized protein can get out of the capillary, but once it hits that basement membrane and the Bowman's capsule side, it can't get through the negative charge and those podocytes on the Bowman's capsule side. The green blob are just various other substances, amino acids, water, glucose is the green, and then we'll just say wastes in the yellow. Okay, these can go freely all the way in, no problems. They're small little particles, they're needed, they get right through. So that's the filtration membrane. Again, looking at the size of the particles and the charges. Now I want to focus on the bottom part. This is the filtration. The hydrostatic pressure is a big letter P. And what does that stand for again? What's the type of, is it hydrostatic pressure? Is it push or the suck? Push. Remember, this is forces. Forces the blood out of the capillaries. The oncotic pressure is your pi, and that's obviously the suck now. And that, what is the major component of our oncotic pressure? Proteins. Okay? Any force that pulls it back in. So, in this middle part, we have our glomerular capillary, and we have our Bowman's capsule side as well. These are the two sides, glomerular capillary and the Bowman's capsule. Obviously, that's where we're going to be pushing stuff into the Bowman's capsule, or we're going to suck things back out of the Bowman's capsule back into the capillary, or prevent things from moving. So this is the blood side, and this is the filtrate. In the blood, the hydrostatic pressure of the glomerular capillary is 60 millimeters of mercury. The oncotic pressure in the glomerular capillary is about 29 millimeters of mercury. These are the oncotic pressures and the hydrostatic pressure just in the capillary as it gets to the nephrons, into the Bowman's capsule. On the Bowman's capsule side, the hydrostatic pressure of the Bowman's capsule is 15 millimeters of mercury. The oncotic pressure of the Bowman's capsule should be what? So the oncotic pressure of the glomerular capillary, which has proteins in it, is 29 millimeters of mercury. That's the oncotic pressure. Should proteins ever get into the Bowman's space? No. So what should the oncotic pressure of the Bowman's space be? 0. Should be 0. Okay, that's the goal. You don't want proteins in the Bowman's space. It alters your oncotic pressure, and you'll see what happens if you start spilling proteins into the urine. You start getting puffy and some other problems going on. So if we take this as a formula now, where we have, on one side, we have factors that favor filtration minus the factors that oppose filtration. Okay, what favors filtration? Of those 4 variables we have on the side there, which ones favor filtration, pushing it into this space? Hydrostatic pressure of what? The glomerular capillary is favoring push. So the pressure of the glomerular capillary, hydrostatic pressure, plus what other of those 4 numbers favors filtration, pushing it into the capillaries? Oncotic pressure of what? Bowman's capsule. Very good. Okay. Okay, all together. Now, minus the forces that oppose filtration, which are the what? The opposite ones. Pressure of the Bowman's capsule plus pressure of the glomerular capillary. Those are factors that oppose filtration. Does everyone understand how that works, why it works that way? Okay. Favors filtration. A high hydrostatic pressure in the capillary is going to push the fluid out, right? So that's going to push fluid out. That favors filtration. The oncotic pressure of the Bowman's capsule, the lower that number is, or the higher that number gets, your filtration is going to get off. Remember, that's the suck. So by having that number there, that's filtration because it's in the capsule side. Because if you have a higher oncotic pressure in the Bowman's capsule, where is that fluid going to stay? Where's it going to go? If you have, okay, let me word that again. The higher the oncotic pressure, or the lower the, I'm confused. Let me think about this first. Okay. Anyway, let me go to the next step because we're going to cancel out some numbers here because where should the pressure in the Bowman's capsule be? 0. So we get rid of it. So what we say is the equation then becomes PGC minus the sum of oncotic and hydrostatic pressures so PGC before we said was what? 60. Plus oncotic is 0, right? Oncotic pressure of the Bowman's capsule is 0. So 60 plus 0. These are factors that favor the push. Factors that favor suck are on the opposite side, which is the pressure of the Bowman's capsule plus what is the pressure, what's the oncotic pressure of the glomerular capillary? 29. So 60 minus, what's 15 plus 29? 44. And we have a positive 16 millimeters of mercury pressure. If it's a positive number, does that favor filtration or absorption? Filtration. So if that number is positive, it favors filtration. The factors that favor filtration are greater than the factors that favor absorption or oppose filtration, put it that way, oppose filtration. So when you're doing this one, remember the hydrostatic pressure is the push, and the higher the hydrostatic pressure in the glomerular capillary, the bigger the push. If you raise the hydrostatic pressure of the Bowman's capsule, are you still going to be pushing fluid in there? If I raise the hydrostatic pressure of the Bowman space? No, it goes down because the hydrostatic pressure in the Bowman space opposes filtration because we already have high hydrostatic pressure there. It doesn't want to go there. They're close to the number to each other. The closer they are to each other, they're not going to move any direction. So when you're studying this, know what's going on in the Bowman space, what's going on in the glomerular capillary. We know we don't want any proteins in the Bowman space. The factors that oppose filtration, what's the biggest one that's going to oppose filtration in that side over there? That one. The oncotic pressure of the glomerular capillary opposes filtration. The higher that number is, it's going to oppose filtration because now we have a very high oncotic pressure gradient, a very, very large suck. It's going to oppose filtration. So anything that opposes filtration, think of protein. If it favors filtration, it's hydrostatic pressure. Yes?
I'm confused about the direction of filtration.
Or filtration is going into the urine, into the Bowman's capsule.
Into the bone.
Yep. Filtration is always into the Bowman's capsule from the capillaries. Yep. I'm not going to give you this formula on your test, but again, these are things to understand the concept when you're talking about when you start changing pressures, what's going to happen with the movement of the filtrate. This last little bit is talking about nephrin. It's just as an example, there's this one disease in children called minimal change disease. They lose albumin like crazy. So because it's a protein in the urine, it's a nephrotic syndrome, and they swell up really bad. But that won't be on your test. Let's take a break, and we'll talk about GFR in a second. Come back at 1:40. Okay, we'll get started, finish up. So, when we want to talk about our filtration going into the kidney, our glomerular filtration rate, there's two things that kind of like go into calculating that. One is the PUF, which is the fluid, the ultrafiltrate, how much fluid actually came out. And the K to the F is basically, is the door open or not, the filtration barrier. Can you get through? Is it permeable? So if an ion or structure or whatever chemical is not permeable, that KF will be basically 0, but it changes depending on the permeability. We don't worry about that one. We worry about the PUF. We know that the glomerular capillary, the filtrate that comes out is a unit of that formula that we just went over before. We have the hydrostatic pressure of the glomerular capillary. The higher that number is, the more it's going to push out to favor filtration. We subtract that from forces that oppose filtration. Ones that oppose filtration are high oncotic pressures in the glomerular capillary. The higher oncotic pressure in the glomerular capillary opposes filtration because it applies a huge suck. So it's going to oppose filtration. The hydrostatic pressure of the Bowman space also opposes filtration. Remember, our hydrostatic pressure the glomerular capillary minus the Bowman's capillary hydrostatic pressure. If that Bowman's capillary, the Bowman space, starts getting more and more fluid in there, what happens to your filtration pressure if the Bowman's capsule starts getting higher hydrostatic pressures? It decreases. That's why it opposes filtration the higher the hydrostatic pressure is in the Bowman's capsule. This will become evident in this slide right here, this picture. So let's set this up. First thing, on the y-axis, we have the pressure. These pressures that were generated via hydrostatic pressure of the Bowman space, glomerular capillary, the hydrostatic pressures of both as well, the oncotic pressures. On the x-axis, we have the length of the capillary. So we're going along the length of the capillary. We'll start on we'll call it the afferent side, and then obviously the efferent on the other side. Because remember, in the renal system, we have the arteriolar, or the afferent arteriole bleed that feeds the Bowman space, and then leaving the Bowman space is the efferent arteriole. So they're on both sides. The blue line up here, hydrostatic pressure in the glomerular capillary. We have the red line, glomerular capillary oncotic pressure. And in the green on the bottom, we have hydrostatic pressure in the Bowman space. Hydrostatic pressure in the Bowman space doesn't change along the length of the tubule. It stays that number the whole way through. There's no changes there. Now, if you look at the top here, the part that's in yellow, area proportional to net ultrafiltration pressure. All of this is what's going into the Bowman space. All that yellow line, if you want to go back to calculus and all that fun stuff, you want to figure out the area of all that, go right ahead. You don't need to. But that will tell you what has been filtered into the Bowman space, that whole yellow line. Now, if we're losing fluid because we're pushing it out, does that make sense why the hydrostatic pressure has a gradual decline as you go along the length of the capillary? We're losing filtrate as you go along the length of the capillary. If you're losing filtrate, hydrostatic pressure has to reduce because you're losing volume of fluid in the capillary. It's going into the Bowman space. Now, as we're losing a little bit of fluid, we're losing the solvent in the solution, the water. The filtrate is leaving. But what molecule does never crosses that filtration barrier? Proteins. As you go along the length of this capillary, because you're losing hydrostatic pressure, you're just losing water essentially, the pressure that those proteins exert gets stronger as you go along the length of the capillary. That's why this red line goes up. Let me change that to a highlighter. Because along the length, you're losing hydrostatic pressure, so that oncotic pressure now has a stronger force. And if you notice, we have this filtration equilibrium. When we hit that spot, the forces that oppose filtration and the forces that favor filtration zero out, and we're not going to filter anymore. This blood will go on to the next nephron, become an afferent somewhere else. The same thing goes on again, and that's how we filter out the blood. So this is, again, just proving to you why we have certain ways set up the way they are with regards to movement of water, why proteins are so important, because without proteins, this whole thing gets out of whack. And if you start having proteins show up in that Bowman space, then you're going to have some real problems with filtration as well. So this is like a determinant of GFR. In the beginning, we have a lot of hydrostatic pressure. The hydrostatic forces outweigh it, favors filtration, pushes fluid into the tubular space. Towards the last third of that capillary, oncotic pressure and hydrostatic pressures even out. No more filtration, filtration equilibrium, and then move on to the next one. So we can alter vascular resistance, glomerular capillary hydrostatic pressure, through changes in afferent or efferent arteriolar tone. Norepinephrine preferentially will constrict the afferent arteriole. Does that make sense? Go back to your fight or flight response when norepinephrine would come out. What are we trying to do? Fight or flight? Run away from something. Run away from a bear. Do we want the blood going to the kidney? No, we can shun it away. So norepinephrine will act on the afferent arterioles and prevent blood from going into the kidneys, because then it will divert to your muscles, wherever it's got to go. So norepinephrine, so we're going to reduce renal blood flow, GFR, and our sodium excretion, because less blood is going to the kidneys. Therefore, everything gets reduced. Angiotensin II constricts the efferent arterioles. So this is after the Bowman space. So what that does, it's going to reduce the blood flow, the renal blood flow through the kidney, but it's going to maintain GFR. So you have to know norepinephrine is the afferent, angiotensin II is the efferents. I don't know why they're so much easier to remember if they were opposites. NE goes to the E, angiotensin goes to the A, but it doesn't work that way. Kind of like everyone watching House of the Dragon, or are you too busy studying? So those two twins, Eric and Eric, the A goes with the greens and the E goes with the A, the blacks. So they could have been the opposite. It would have been easier like this, but oh well. Okay, let's talk about now what's going to happen. So here is the Bowman space right in the middle. Okay, here's your whole Bowman's capillary. We have blood coming in and blood coming out. This is the afferent, and here's your efferent arterioles, remember? Here's our Bowman's capsule, and our renal blood flow goes in this direction. So, with a constant renal blood flow means constant oncotic pressure in that Bowman's, in the glomerular capillary. Therefore, constant GFR. So when everything is wide open, we're good. Constant flow, constant perfusion, or filtration, constant GFR, glomerular filtration rate. That's what we want. That's during normal activity. Now, let's change the afferent arteriole. What are two things you can do to an arteriole? There's only two things. Constrict or dilate. So let's change it up. Let's constrict it. Okay? So we're going to constrict this vessel going in. Coming out, still normal. We have not touched the efferent side. We're just touching the afferent side. Let me bring this up and blow it. Okay? With constriction, what's going to happen to the renal blood flow that's coming into this area? Decreased. Very good. We're going to decrease renal blood flow. If we're decreasing renal blood flow, what is going to happen to the hydrostatic pressure in that glomerular capillary? Who says increase? Raise your hand. Who says decrease? Raise your hand. It decreases it. It can't get through. We have a constriction. So it's going to decrease the hydrostatic pressure in the glomerular capillary. Less blood is getting in there, less hydrostatic pressure. Less hydrostatic pressure, what happens to the GFR in this situation? We have a reduction in GFR. Therefore, less urine production, and we'll have problems that way. So this is what happens when you constrict the afferent arteriole, reduces renal blood flow, reduces hydrostatic pressure in that capillary, therefore reduction in glomerular filtration rate. That's with constriction. And what substance can constrict this? Here's your norepinephrine. Now, let's do the opposite. Let's dilate it. Okay, now we're going to get a fat vessel going in and a normal one going out. So we've dilated it. What's going to happen to the renal blood flow with that dilated artery? So you have more blood going in. What's that going to do to your hydrostatic pressure? Increased your hydrostatic pressure of the glomerular capillary, which then does what to your GFR? Increases your GFR. So we have a lot of blood coming in, builds up pressure there, so more factors that favor filtration. And it all goes up. So if you dilate the afferent side, more blood gets in, more hydrostatic pressure, favors filtration, increased GFR. Everyone good on the afferent side? Okay, let's talk about the efferents. With the efferents, there's a couple of things that can happen. We can have mild constriction. So coming in, we're okay. Now we're having a problem with leaving. Very, very, very tight. So think of this as like a traffic accident. You can't get through. Okay? So where's all that pressure going to build up? What happens to our renal blood flow when we constrict the efferent side? What do you think happens? We're going to decrease it, right? Because we're still constricted on the afferent side, so we're going to have reduction in renal blood flow. However, where's all this blood going to fill up in? It can't get out of the Bowman's capsule because the efferent side is mildly constricted. Where is this blood going to start building up? We'll go right backwards. Where's the next spot? Bowman's capsule. So what's going to happen? Increased hydrostatic pressure of the glomerular capillary, pushing all that fluid out because we've mildly constricted that side. Hydrostatic pressure builds up because that blood is getting stuck in those glomerular capillaries now. They can't get out because the efferent side is constricted. It's going to start building up in the Bowman space. Hydrostatic pressure goes up, favors filtration, pushes the filtrate out, so our GFR goes up. Everyone good on that one? It builds up inside the Bowman's capsule, glomerular capillary hydrostatic pressure goes up, increasing factors that favor filtration, and we get an increased GFR. The next thing that can happen, we can have extreme constriction. Now we're basically almost blocked off. We have a very, very tight vessel there, very, very tight. What's going to happen to your renal blood flow in this situation? We're still constricting the exit side, the efferents. What's going to happen to the renal blood flow in this situation? Decreased, less flow. We're causing constriction. In this scenario, though, again, that blood is going to back up into that Bowman space and start exerting a lot of hydrostatic pressure. But because this blood is not really moving very well, the oncotic pressure starts building up more. And when that oncotic pressure starts building up more and exerting a bigger influence, increased oncotic pressure of the glomerular capillary, is that going to favor filtration or oppose filtration? It opposes filtration. So what do you think happens to our glomerular filtration rate? It goes down. This is the big difference between extreme constriction and mild constriction. In extreme constriction, you're going to reduce your GFR. In mild constriction, the GFR is still okay. So we'll talk about what happens when we give drugs that can really cause problems with this efferent arteriole and why we avoid them with certain patients. The last thing we haven't talked about is what? We've constricted only, dilate. Let's dilate that efferent. So we dilate it, make it big. So the efferent side is wide open. What happens to all that blood flow through that area? Just flies through because we're wide open on the other end. We're still open on the entrance. Exit's wide open. Renal blood flow goes down. I'm sorry, it goes up. You said it right. Now, because that blood is moving fast, what happens to the hydrostatic pressure inside the glomerular capillary in the Bowman space? It's going to go down. Now the blood's moving too fast. Gets out too fast. So we get a reduction in hydrostatic pressure of the glomerular capillary, which does what to the GFR? Decreases your GFR. So even by dilating the efferent side, you cause problems to your patient if they have kidney issues. I'll get to that in a second. Everyone understand? So when you're studying this, make sure you got to know, I'll ask you a question. If I mildly constrict the efferent side, what happens to GFR and so forth? Stuff like that will be like a typical question you'll get for the renal side. So Clinical correlation. Renal insufficiency can be caused by some drugs. First one, NSAIDs. Okay, you don't want to give, like I said before, you don't want to give NSAIDs to people who have kidney problems. That's where that's where it goes through metabolized. Here's the other problem. NSAIDs inhibit prostaglandins, which are primary endogenous vasodilators of the afferent arteriole. Okay? So if you reduce prostaglandin levels, it will cause vasoconstriction of the afferent arteriole, decrease your GFR. So you have a patient who's already got kidney failure, and you give them NSAIDs, which makes their renal blood flow even worse, which makes their GFR go down even worse. So you don't give NSAIDs because it affects the afferent arteriole. Conversely, we have classes of drugs called angiotensin-converting enzyme inhibitors, ACE inhibitors, or ARBs, angiotensin II receptor blockers, both involved with that renin, aldosterone cascade, the whole thing. But remember, angiotensin II has an effect on the efferent side, right? So if we decrease the amount of angiotensin in the system, it's going to decrease GFR due to vasodilation of the efferent side, which is why you don't give ACEs or ARBs to kidney failure patients. You're going to make their filtration even worse because you're reducing angiotensin II, which is on the efferent side. We know we're going to cause this vasodilation. We know when we have vasodilation, blood goes too fast, there's reduction in hydrostatic pressure, filtration goes down, and you're making their kidney function worse. So that's it, how we can talk about afferent and efferent arteriolar constriction, how we can modulate those things to help improve kidney function or even worsen it depending on what's going on. Another thing we need to talk about with kidneys is clearance. We need to get rid of substances in the blood. So clearance by itself, definition, volume of plasma rendered free of a given substance in 1 minute. So obviously we have to know renal blood flow rates and so on and so forth. I'm not going to ask you to memorize this formula. It's just there in case you're wondering when to figure it out. But just know that clearance is how much of a solid we can get rid of in 1 minute. Out of the solid into the urine. So obviously we have to measure the urine flow to see what's the concentration in the urine to figure out clearance. We use it for creatinine. Creatinine clearance is the value that you get on your lab results, CRCL. Creatinine clearance, how much we can get rid of. Creatinine is a product of muscle metabolism. So we know that the rate of creatinine production is constant because it's constant with your muscle mass. So people who are smaller are going to have a lower creatinine clearance versus someone who is a lot larger because of muscle mass. That does not mean that the smaller person has bad kidneys. They just don't have the muscle to give a bigger number for the creatinine. That doesn't mean anything. You look at the ranges. Mainly, I don't even like to look at creatinine clearance, look at GFR for the most part for when it comes to like kidney function. I'll tell you more. Creatinine clearance overestimates GFR by about 10%. Because the creatinine production is constant, the excretion rate will only vary depending on whatever your GFR is. If your GFR goes down, you can't clear as much. So what happens to the creatinine numbers in the blood if you can't clear it? It's going to go up. So therefore, as the GFR goes down, which means your kidney function is getting worse, your creatinine clearance goes up. Because it's going to remain in the blood. You're not going to be able to filter it out, so it just sticks around in the blood longer. So that means your creatinine is going up because you can't clear it out of your system. Any questions about that clearance? We mainly just use creatinine for that. Quantifying tubular function. Okay, we want to know how much stuff we put into the tubular filtrate and versus what goes into the urine. What was taken out, what was left in. So the filtered load is just the amount of substance filtered by unit time. This was what going into the Bowman space. the filtrate. How much do we dump in there? The excretion rate is the amount excreted in the urine. So the rate of net tubular transport is the difference between what's filtered into the original, what's dumped into the solution, and what actually winds up in the urine. If the excretion rate is less than the filtered load, then we have reabsorption, because the excreted rate is less than what was filtered. So we had to have reabsorbed it because it didn't come out in the urine. If the excretion rate is greater than the filtered load, that means we had to add more stuff into it outside of the Bowman's capsule. Anytime you add a substance into the tubular fluid outside of the Bowman's capsule, it's called secretion, because you're adding more to it. If I dumped into my tubular fluid 10 units of potassium, but then I look at my urine and I have 13 units of potassium, well, I have more potassium in the urine than I did in the tubular fluid, therefore I must have secreted some along the way to get it in there. If I dumped in 20 units of glucose into the urine, into the tubular fluid, and I excrete 0 units of glucose, where did all that glucose go? I reabsorbed it back into my body. So that's the reabsorption. That's what we're talking about here. Did we secrete more substance and more of it came out in the urine than went in? Or did less come out in the urine than went in? We knew we had to reabsorb that. We also look at fractional excretion. This is the solute concentration as a percentage of filtered load. This is useful because it shows changes in tubular transport, not just how much filtrate are we able to get in there. What's going on with the actual tubes itself? So we use a clearance ratio, and basically the rate of solute clearance to creatinine clearance. That's our creatinine clearance is our normal, and we relate other things to it as well. So you'll see fractional excretion come up a lot when we talk about mainly potassium, because that gets altered a lot right at the very end of the common collecting duct. So clearance of a solute may change as a function of plasma concentration. Glucose is not found in the urine with normal plasma concentrations. Normal glucose, 60 to 100. When you start getting high glucose readings, like in diabetes, the filtered load is increased. We're dumping a lot of glucose in there. So the filtered load increases, but the reabsorption mechanisms may be saturated, meaning we only have a certain number of ways that glucose can get back in. There's only a certain amount of transport mechanisms. Think of them as cars. There's only a certain amount of cars. If you have more people than cars, what happens to the people? They gotta sit around and do nothing. They can't go back, they can't go anywhere. That's what happens with this. We have so much glucose because they have diabetes going into the urine filtrate that all their transport mechanisms to get all that reabsorbed are all maxed out. And what happens, whatever left over, it stays in the urine, and then it goes out, and then when you check your urine, you'll see glucose in there. If you see glucose in the urine, that means they've had high sugar for a very long time, and they just can't bring any back into the system. So there's this graph here, these renal titration curves. Don't go crazy, try to know what this is. This is just, again, this picture is just to show you with these transport mechanisms, there is a saturation point. So this is looking at plasma glucose. Your normal glucose is right here in that typical physiological range. That's your normal glucose. And if you look at here, it's probably 60 to 100 is that bar. That's a normal blood glucose level, 60 to 100. And when we have that, the filtered load is easily reabsorbed, which is that green line. When they're together, that means we're able to reabsorb all that glucose and it'll never appear in the urine. However, as you start getting around 200, constantly, not just because you ate something and went up to 200, you're fine. Constantly in this 200 range, you'll see excretion. Now we're starting to see glucose in the urine because the transport mechanisms have all been saturated because we have too much glucose. We can't reabsorb it. So there's this definition, it's called splay. This is the splay right here that I'm coloring in. What does this mean? It means that not all the mechanisms shut down all at once. It's a slower process until we are totally saturated. So it starts to curve because we have less ability to reabsorb these things. It's just called splay. It's just this deviation from our normal line for the reabsorption. And then you see here, reabsorption flattens out. We cannot reabsorb any more glucose, roughly about 400. If your glucose levels are over 400, you're going to spill the majority of that into your urine. We just can't reabsorb it. But 60 to 100 units going into your filtrate, we have enough transport mechanisms for all those glucose units to get them back into the blood. But when you start building up concentrations of glucose due to diabetes, more and more urine will get covered, have the glucose stay in there in that tubular fluid because we can't get it out anymore. Did you guys hear that? I think there's a distillery who's making bourbon or whiskey out of diabetic urine. Because of the sugar content, they can distill it, and people do weird stuff. You hear that the squirrel poop that makes the coffee beans? The squirrels can't digest it, so they eat it, but it ferments in their body, and then they poop it out, and then people will take the beans and roast them and brew coffee.
It's on Amazon.
Yeah, people do weird stuff. So here's that splay. I'll keep distracted. Okay, curve levels off gradually, which is splay. Variability in transport between nephrons. Not all nephrons act the same. Okay, some are slower than others, but when you get to a higher concentration, you have to use more and more nephrons to deal with all this stuff, and some of them don't work as well. So this is just saying, this graph, all you have to know from this, with certain concentrations, we can't bring any more in. And it's all within, now this is glucose. Other substances have their own graphs, but for glucose, this is the way you figure it out. The higher the glucose in your blood, we can't reabsorb all of it. Some of it stays in the urine, and it goes out. So presenting symptoms for hyperglycemia in an untreated diabetic, they get polyuria. What's that? Increased urine. So why? Once our transport mechanism for glucose is surpassed, glucose and water remain in the urine, causing an osmotic diuresis. Glucose is in the urine now. It's going to want to dilute that out. So it's going to add more water in. Therefore, you're going to create more urine. You're going to pee more. Polydipsia, what's that? Increased thirst. That osmotic diuresis we talked about above causes free water loss, increasing your serum osmolarity, because you're losing water, so all those solutes have a bigger pull now. Okay, we get osmoreceptors in the hypothalamus, increased sensation of thirst. We need to drink more because of the osmotic diuresis caused by the urine. And finally, hypovolemia, the polyuria, and the water loss cause hypovolemia. Because again, osmotic gradients are set up, water goes into the urine, you lose water out of your blood volume, and your osmolarity goes up, drive receptors for thirst. And we'll stop here. So we'll answer our diuretic question tomorrow. Tomorrow we'll do our Kahoot review for your test on Friday and continue on. See you guys tomorrow.